Good morning, afternoon, or good evening, everyone, as we gathered here today, joining from different parts of the world and different time zones. I would like to extend a very warm welcome to each of you. Welcome to our much anticipated webinar, Innovations in Suction Technology, Enhancing Efficacy and Safety in Endourological Procedures. I'm Kasia Korab from Pusen Medical Business Development Team, and it's truly a pleasure to see so many professionals gathered here today. First and foremost, I'd like to extend a warm welcome to each of you for joining us from around the globe. And I would like to extend a special thanks to Dr. Pablo Contreras, our course director, alongside with Dr. Karen Stern, Dr. Frédéric Panthier, and Dr. Eugenio Ventimiglia for sharing their knowledge and their expertise. Let me add that today's webinar will be recorded and will make a contribution to DISS Scope Academy library, making use for future learning. And well, as we embark on this journey of knowledge and experience sharing, I encourage everyone to actively participate in the discussion that follow. Today, we have a rich agenda touching on recent topics in endourology. So without further delay, let's dive into what promises to be a truly enriching and fruitful experience. Thank you all for joining, and I wish you a very rewarding time ahead.
Thank you very much, Kasia. I will share my screen. I am Pablo Contreras from German Hospital in Buenos Aires. Thank you so much to all the colleagues around the world connected with us today. And in the next 60 minutes, we will discuss with this amazing panel of experts and all the topics about suction, about lasers, about setting. So please be welcome to do your questions, to type your question. And at the end of the lectures, we will discuss with the panel. Thank you so much for our great speakers. The first one will be Dr. Frédéric Panthier. Frédéric is from France, from the University of Sorbonne, and his lecture will be about what is stone dust and what are the implications for suction. So, Frédéric, welcome. Thank you so much for accepting the invitation to the webinar, and you can share your screen.
Thank you, Pablo. Thanks for inviting me. It's a real pleasure to be with you guys today. So, do you all see well my slides? Is it okay?
Yeah, very well.
Perfect. So, again, thank you for giving me this topic to treat. What is stone dust? What are the implications for suction? Here are my disclosures. The first slide. Okay. Here are my disclosures, and we're gonna dive into the topic today. What does it mean, dust? I mean, dust, we all know the definition of dust according to the common sense, but what does it mean regarding stone? And when we look from an historical point of view, we can see that the first mention of dust was in 1987. And since that, there's been like several definitions according to several criteria. Size, in vitro, in vivo conditions, the ability to be aspirated through a walking channel, or composite definitions. But all of these definitions will agree that dust is a thin pulverization from a stone. And then what is really dust? Dust is, first of all, stone. So when we are speaking about dust, we are speaking about urinary stones, and dust are obtained from urinary stones. But when we analyze dust under the microscope, dust are not as good as fragments. For example, in this study, when they analyzed and compared dust and fragments after MOSIS technology lasering, you can see that there was laser conversions. There were changes also in crystalline organization on the dust compared to the fragments. Again, we have the same results, similar results with thulium fiber laser. Dust are not similar to fragments. Dust are good for analysis when you have nothing else, but fragments are better because you have in 25% of cases one missing component, you can have laser conversion from monohydrate to dihydrate and change in proportions. So dust is stone, but dust is not as good as fragments. And something very important, it's not only for the stone dust definition, but it's for everything in endourology, that we are very good at providing definitions from in vitro, from the lab, but going from the lab to the theater, from in vivo conditions, we have very high expectations. And this expectation has to be reasonable when it comes to go to theater. Otherwise, we are going to put ourselves and the patient in danger. For example, with the thulium fiber, we've been hoping to use very high frequency, similar to the lab conditions, but it's not possible into a theater, into real life cases. So we're going to talk about lab definitions and in vivo conditions. And from the lab, we have this composite definition, which is the last one and maybe the most accurate one to my opinion, that stone dust is small particles that respects these three criteria. First is the ability to under irrigation, a regular 40 centimeter water irrigation. Then to be able to sediment and to take more than 2 seconds to sediment through a 10 centimeter saline solution. And the last one is the ability to be aspirated through a 3.6 working channel. So when you take these three criteria, the definition of dust for all human urinary stones compositions are, and the size is 250 micron. I must acknowledge that for struvite infectious stones, it could be considered at 125, but let's say it's 250 for all human stones type. That being said, which laser is able to achieve stone? I'm not going to spoil Eugenio, but it's very important to know that in vitro, all technologies, all available technologies have been able to achieve stone dust for all human stone compositions. Holmium YAG, low power, high power, no debate about that. Thulium fiber, and more recently, the pulsed thulium YAG laser. But this is in vitro. When you look at what is available and recommended in vivo, according to the very last EAU guidelines 2024, only holmium YAG and TFL are allowed to be used in clinical practice for lithotripsy, especially during flexible uteroscopy. So I would say that we can use only holmium and thulium fiber for dusting in clinical practice. And when we try to compare them, we can see that the thulium fiber is better than the holmium YAG on the dusting ability, but because when you look at these RCT results on the zero fragment rate, you can see that the thulium fiber had a very much higher zero fragment rate than the holmium YAG during ureteroscopy. So thulium fiber will be a better duster. But this is the only evidence we have about in vivo dust definition. The definition for intraoperative stone dust can only rely on small particles. We don't have current technology to measure the fragment size. Can we really define dust and residual fragments? Difficult task. And also, does it really matter to define dust if we are able to aspirate all the fragments? And does it really matter at the end? But before discussing that, what happens to dust? What can happen to dust? First option, spontaneous elimination. You see this very nice cake, large stones, and on the double G, no, it's what is called zero fragment rate. However, it's not every day like this. We have to look to the two other options. If you have retained dust, you have to discuss and you have to acknowledge that it can happen an early recurrence. The retained dust in this case in the lower pole calyx of uric acid stone former resulted in an early recurrence of a 20 millimeter lower pole stone. So my advice for that, the trick and tips for that would be to be patient and also to use a basket as long as it is possible. The last option is that the stone dust is going into the urinary tract between the kidney and the bladder and creating not really a trench tracer anymore because it's not fragment, it's Senstrasse. So you have to understand that Senstrasse is a risk in 2024. To limit that, we can limit ourselves to 90 minutes of operative time and operative duration, because when we limit ourselves to this time, the amount of dust we can produce is also limited. So we have to understand and we have to be reasonable with ourselves and with the patient to avoid this Senstrasse risk. Then we can use suction device. Suction device can help to limit the amount of retained dust at the end of the procedure. And in cases of Senstrasse, we can propose to go back to theater and to do a stent exchange. During the procedure, you can also use a scope, a flexi or a rigid one, to go and to see if there is only dust, or if there is more than dust, some big fragment that you need to retrieve with a basket. But otherwise, if you pull the stent, you will see the plug. So there's the same plug coming out through into the bladder from the ureter, and that way you can put another stent and drop the obstruction. But let's get back to our discussion. Today, at the moment, to the best of my knowledge, we don't have any accurate fragment size measurement. So for that, I can propose you to compare the fragments with the fiber. So, but be careful. When you compare the fragment with the fiber, be aware that the fiber diameter is different from the core diameter. When you ask for a fiber, a laser fiber, you ask for a 150 or 200 microns. But this is only the core diameter. It doesn't take into account the outer diameter with the coating. So for example, here is a case of a 150 micron fiber. Actually, the core is 160 micron under optical microscopy, and the outer diameter taken into account resulted in a 230 microns laser fiber. So I would say if you compare your fragments with this fiber, maybe you can see and you can say that your fragments are over or not 250 microns, the limits from in vitro studies we have. And what is the future? But the future is here. We have artificial intelligence already during flexible ureteroscopy for endoscopic stone recognition. So we are able to automate the stone recognition. We are able to automate the stone measurement, linear and volumic. So we are already good for that. And moreover, we can automate the object recognition, the laser fiber and the stone, based on images and video clips. So we know that deep learning, neural networks, artificial intelligence will sort our ability to measure the fragment as measurement and to be able to accurately define the fragment size intraoperatively. It's even more a reality that we are not able at the moment to differentiate. We're not able to differentiate dust and residual fragments. It's very important to understand that, because the residual fragments definition we have at the moment are based on post-operative KUB, ultrasound, CTs. For example, for shockwave, it's only on KUB on very, very old studies. And clinically insignificant residual fragments are defined as less than 4 millimeter residual fragments. For Flexi, it's based mainly on CT now, and it's less than 2 millimeters. But this is not intraoperative technology. So we have to develop it if we need it. But do we really need it? At the end, if we are able to aspirate what is on the left side, pure dust, or on the left side of this, like dust and small fragments, really matter to be able to know the size. And this is the discussion about suction. We have three options to manage suction. The first one is more historical, the ureteral catheter, the 5 French one, and we have more current one, I would say, the suction ureteral HHCs and the suction scopes. You can see on this slide that creates various number of fragments of 250 microns at the same time through these three options. Through the 5 French ureteral catheter, you can aspirate 40 fragments. Ureteral HHCs, you can aspirate 250 for 12 French. And through the working channel of a flexible scope, we can aspirate 23 fragments. So there are concepts. We have to accept these concepts, and you have to optimize them to enhance the suctionability. So the first one, it's more historical, I've told you before, and it was for impacted stone in the ureter. So it's not really something we can export to the renal cavities. And we also see that there was no real difference at 1 month after surgery in terms of success. So it was a good idea, but was not the revolution. This was maybe not the revolution, but a good evolution, I would say. Suction ureteral HFC, the first version was not able to deflect, but the current one is now able to deflect its active and passive deflection with the help of the scope. But be careful, this is dangerous devices if you don't use them properly. For example, you have to put them and place them into the renal cavities over the PUJ with narrow PUJ, or in case of non-Princeton cases, it could be difficult to handle and it can create injuries. So be careful with this device. It's a very, very nice device that you can use in 2 ways. First one is to aspirate the dust, the 250 microns. And the second version is to use this device with the vacuum cleaner effect. It's similar to mini PCNL at the end. You can use the Venturi effect to aspirate 1 millimeter fragments. And I would like to thank Anil for providing me these videos recently. I mean, it's very important for us to understand that we can use this tool in 2 different ways, combined depending on our technique. When you look at the results about suction ureteral HFCs, you can see on this very large evaluation that the stone-free rate of fragments less than 2 millimeters is 97.2%. This is very high and very encouraging, but this is from experts. So experts have very good results. Key opinion leaders are very good, but do they represent the reality and the average level of urologists? Maybe not. So take that into consideration before using suction ureteral HFCs. The last option is in-scope suction. You can see on the right side of the slide the first homemade version, and on the left side the current Pusen 7.5 French scope with suction. You can see the results of the first evaluation done by Vinit Gowar, our colleague, who showed that there was a similar stone-free rate with in-scope suction that with suction ureteral HFCs. So it was a good idea, and it was developed then as the current version of the flexible scope we can see. But when it comes to 3.6 French, smaller is better, meaning that the better duster you are, the smaller the fragments are, the more efficient it's going to be when you're going to try to aspirate them, and when we're going to try to avoid blockage. Because there is a risk of blockage, so we have to understand that, and that's why we need to go farther into the dusting. And we have 2 concepts. Really, we have 2 concepts, the in-scope suction and the fans. The fans is a flexible and navigable suction teeth. It's the same that suction ureteral HFCs. And when you're using the fans, you're mainly aspirating the fragments around your scope. And when you're using the in-scope suction, you're aspirating through the working channel. So really 2 concepts, but we can combine them. And it's maybe the good idea. Maybe the idea is to have several tools and to use them jointly. What is the best side of the scope with the suction ureteral HFCs? We are not sure at the moment, but what we know is we need to have some space. We need to have some space around the scope into the ureteral HFC to allow the suction of the dust while continuing and pursuing the lithotripsy. But what are the next challenges for dust and suction? To control it, control suction, because the risk of a too high suction is to have a bleeding, an impairment of a visualization impairment due to bleeding, and this is due to the renal cavities collapses. You can see on this video that you can find on Urology Video Journal from Vinit Gowar that in his first cases he showed this risk. It was described for 46.7 cases. So it was not something you can not know before using that. So we need to understand how to control the suction and how to manage the inflow and the outflow. Is it only for the scope, only for the fan, or between the two of them? It's very complicated. The other option for us in the future is to have two working channels, two 3.6, one for inflow, one for outflow. And maybe for that, we need to go back to 9 French scopes, maybe. We need to select our cases for which we can put a 9 French scope into the brainal cavities. So maybe pre-stented cases, maybe it's going to reopen the debate about that. And the last point I want to treat about that, about dust and suction, is we now know and describe our cases using the stone volume and not only the maximum diameter preoperatively. But now we need to use also the same criteria, the same 3D criteria on the postoperative assessment of residual fragments. You would say on this slide that a 2 millimeter residual fragment has a lower volume than the 5 millimeter residual fragments. I would say, okay, but what if you look at this case, 2 5 millimeter residual fragments, and there is more than a difference of twofold between the two cases? So what is the risk of recurrence from the left side, on the right side, from the residual fragment? We don't know at the moment, so we need to define what is the volumetric stone-free rate. So we need to move from linear measurements to volumic measurements, both preoperatively and postoperatively. So in conclusion, we know from the in vitro studies that stone dust is 250 micron. We know it, but how does it translate clinically? Maybe artificial intelligence will help us to have a good and an accurate measurement intraoperatively, and I hope it will come in a very close future. Suction is a game changer. So we have to develop new devices, and we have to understand that TNT is not only tips and tricks, but it's also tools and technique. And tools and techniques mean that we can use tools and adapt our technique, or we can develop tools to our technique. And I'll thank you very much for your attention.
Thank you so much, Frédéric. Wonderful lecture. Before to introduce our second expert, I would like to thank Pusen, Cassia, and Wendy Gao for giving us the opportunity. We truly believe that education is the key for excellence. So I appreciate, and we all appreciate the opportunity to share our knowledge with you. Can you please stop your sharing? Oh, thank you, Frédéric. So our next speaker, it's Eugenio Ventimiglia. Eugenio is an endourologist, is a great expert from Italy, from San Raffaele Hospital and University. And Frédéric spoke about technique and about settings. So please, Eugenio, give us your lecture and clarifies which laser and which settings are needed for suction procedures.
So good afternoon, everybody. Thank you, Pablo, for this kind invitation, and thanks to Pusen also for the possibility to discuss about these topics. Actually, they are very interesting, and they are part of my both clinical and research activity, and I'd be very glad to discuss them with you today. So Dr. Panthier was really skillful and clear and precise in telling us that stones ends up in fragments, dust, what is dust, how dust is impacting our outcomes, and actually what really matters during our practice and when we are trying to improve and to implement our ureteroscopy with aspiration. Dr. Panthier was super clear. He said that if you are going to go for direct intrascope suction, what you really need is to have as much as dust and again dust as possible. Whereas if you are doing aspiration through an access sheath, of course, you can negotiate to have some small fragments because you have this kind of vacuum cleaner effect that eventually will improve you and will help you in order to, let's say, evacuate them in certain under center conditions, of course. And at the end of the day, the question that you have to ask yourself is that how to obtain dust and how to obtain the finest and the highest quality dust as possible. Let's discuss lasers then, because lasers are what actually are creating dust. aside with your technique. Laser is light, of course. I will not spend a lot of time telling you what is laser, because that is boring or can be boring and would bring us away from the main topic of the discussion. But again, what I want you to focus on and to be clear is that we will discuss all those lasers that are actually used today. Of course, holmium laser, you know it very well. It's been with us since 30 years. But there are two new kids on the block, thulium fiber laser and thulium YAG, which can be used pulsated for stones. Of course, they should not be confused. And we're going to discuss in a while what are these novelties and how they can help us producing dust. Again, just a few concepts. Remember that whenever you are choosing a laser and the settings, you are going to influence the outcome of your procedure, because lasers, they act in water, they have different profiles and different mechanisms of working and interaction with the stone. And at the end of the day, if you want to have dust, what really matters? Is it matter of laser type, laser power, settings, or technique? So just to be clear, whenever you are treating stones, you have to use pulsated laser and non-continuous lasers. This is a very simple concept. Another concept that you have to take into account is that you need to choose a laser with an adequate power. If you are trying to use stones and stone is your only business, of course, you don't need very high power lasers, because both low power lasers and high power lasers will do a good job. A little bit more boring how the laser works inside the machine. We don't really need to spend a lot of time on it. Just remember that holmium YAG is holmium because it has a holmium YAG rod, which is excited by light, and at the end of the day will produce this type of laser emission with this length wave. Very similarly, of course, also thulium YAG. The difference is that you have laser diodes instead of a lamp. A little bit different is thulium fiber laser, which has thulium within his silica fiber. But again, not a lot of time to be spent on this, because the most interesting part is what happens in the kidney when the light of the laser hits the stone. How to achieve this very good dusting that Olivier Traxer has taught the world to obtain? Very simply, the first thing is that whenever the laser interacts with the water, you create a bubble. This type of interaction with the water and with the surrounding mean that you have in the kidney kinds of vary with the type of laser that you are going to choose for different factors. And this has an impact because different lasers interact differently with the water. And of course, different lasers have different ways to deliver energy to the stone. Just remember, there's some laser and some specific setting of the lasers, they can deliver the same amount of energy in different ways. So if you have the same amount of energy, which is delivered with a very long pulse duration and a very low peak power, the same level of energy will be delivered to the stone very gently and in a very, I would say, calm way. Whereas if you try and if you decide to deliver the same level of energy with a very high peak power in a very abrupt, in a very, I would say, powerful way, this will interact differently with the stone. And just to be clear, if you want to obtain good dusting, at the end of the day, what matters is to have a lower peak power, a more gentle delivery of energy to the laser. And those lasers with a lower peak power, with a longer pulse duration, will be those lasers which will help you eventually to obtain a good dusting. In a way, we have different ways of interaction of the laser light with the stone. Again, not a lot of technical details because they become boring, but what you see here is that you have the light that can interact directly with the stone, but you also have the bubble which can interact directly with the stone. And when the bubble is a very abrupt bubble, like the one that you see here with holmium, the result is that you have a very explosive bubble, and a very explosive bubble at the end of the day will cause a real explosion of the bubble in front of the stone, which will cause, for instance, with holmium YAG, an explosion of the bubble in front of the stone, a very high peak power, which will cause more fragmentation. And very simply, if you decide to go for lasers with a longer pulse duration and a lower peak power value, you will have a smaller bubble and more gentle delivery again of the energy to the stone, which will help you to deliver this energy more gently and to have lower production of fragments and more dust production. Dr. Panthier described before that there is some time of pulse modulation that you can achieve with holmium YAG, because with holmium YAG, the issue of peak power and high peak power can be important in terms of retropulsion and fragments production. So there is a way to lower the total peak power of holmium YAG, both with pulse modulation, with longer pulse duration. But what new lasers can achieve in terms of dusting cannot be reached by holmium at present. So we started with this question: what really matters in terms of lasers and lasers characteristics in order to obtain dust, and what's the secret to obtain dust? We already spoiled a little bit before with Dr. Panthier discussion that laser matters, and laser matters a lot. Different type of lasers, for instance, thulium fiber laser and holmium YAG, it's been known since many years that they obtain different type of dust and different quality of dust. The dust that you're able to obtain with thulium fiber laser is much finer and definitely not comparable with the one that you obtain with holmium YAG for all the technical reasons we've been seeing before. Also, of course, you have the collateral advantage that you have smaller and shorter retropulsion with thulium fiber laser, so the stone doesn't go and doesn't escape from the laser fiber tip, and this makes your dusting procedure easier. That is important. And also the question that many people are asking for, is it important to have a high power laser in order to achieve good dusting? And if you look at the data in the lab, yes, it is important, because the more power you put in your laboratory conditions, the finer dust you're going to achieve, and the quicker you will achieve some dust. But like the Mount Everest that we've been seeing before, the lab is the lab and the reality is the reality. And if you are going to compare clinical studies, and if you look and if you have a look at the European guidelines, what's been shown also in randomized trials is that you do not increase the quality of your procedures going with high power lasers, which is an indirect proof that high power lasers in vivo do not improve the quality of your dust production. Of course, it is a matter of settings. According to the way you set a laser, you will have different qualities of dust that you will end up producing. And this is a very notorious, I would say, collection of video and important information from Professor Traxler. You see here that those settings that were, let's say, found for holmium, they were very clearly defining the way you could produce dust, fragments, or popcorn at the end of the procedure, your stone. It's very simple, of course. If you want to start and to obtain real dusting, you will have to go for lower energies. And again, to set the frequency high, but not very high, in order to improve the speed of your procedure. It's easier with holmium, because with holmium be staying with us since 30 years. It is a little bit more complicated with new lasers, and especially with thulium fiber lasers. This type of laser has been with us since 4 or 5 years. And if you have a look at how the story started, you see that back in 2021, after a few months of usage of this laser, the real parameters that were used, they were very low energy and very high frequency. But if you have a look at what happened just 1 and 2 years afterwards, what happens is that all the settings that are starting to be used more and more commonly in order to obtain dust are those that are resembling really, really much the one that we've seen before for holmium YAG. And there is a trend toward higher energy, or a little bit higher energy as compared to what was used in the beginning, as compared to what was taught by the lab studies. At the end of the day, I'm not going to spend a lot of time on this study because Dr. Panthier described it very well before. But again, the fact that we have lower residual fragments with thulium fiber laser can be considered as an indirect proof that we are having a better quality of dust production with this type of laser. It is also a question of surgical technique. The historical dusting technique for production of dust during lithotripsy procedure was the so-called painting technique. Again, the way that we have to implement aspiration during our procedure, I'm sure will change this a little bit. It is not taken for granted that dusting can be necessarily better than fragmenting, but I'm sure that with improvement of technology and with all the new direction that we're going to take in order to improve our procedure, the technique might change a little bit from what we were using to do until a few years ago. Just a quick reminder of what we've been discussing in terms of different lasers. You see that the explosive bubble of holmium YAG is due to this very high peak power, which is good for lithotripsy, but is not as good as the smaller bubble of thulium fiber laser when you want to achieve very thin dust production. As you can see, the peak power of thulium fiber lasers is 20 times lower as compared to the holmium one. And also thulium YAG in its pulsated way of working can be really, really helpful according to this type of theoretic working of the laser. Just a quick description of these typical settings for the lasers. And at the end of the day, if we want to compare different lasers in order to achieve good dust production, we need to remind that holmium YAG in its original way it was introduced in the market is a laser which is going very much towards production of fragments. It can be improved in terms of dust production with longer pulse or with pulse modulation. But at the end of the day, what really makes the difference are the new lasers in terms of dust production with thulium fiber laser and pulsated thulium YAG, which is situated halfway between holmium YAG and thulium fiber laser. And with this final conclusion, I would like to thank you for the attention and for the possibility to discuss this very interesting topic. Thank you very much.
Thank you very much, Dr. Ventimiglia. Amazing lecture. So we will add all your knowledge on your conclusion. And it's a pleasure to invite Karen Stern. Karen is an associate professor of urology in the Mayo Clinic in Arizona. And with Karen and with Frédéric and with Eugenio, we will discuss some clinical cases, daily cases. All of them are real cases. So welcome, Karen. Good afternoon for us.
Yeah, thank
Good
you.
morning for you. So here we have a lady, a 26-year-old lady. She's asymptomatic. And in the lower pole of the left kidney, you can see the small volume stone, the 689 Hansfield unit. So Karen, there in your center in Mayo Clinic, what's your first approach in a case like this?
Sure. So I think, it's really patient dependent. I think talking to patient about their goals, what's most important, their prior experiences, have they ever had a stent before? Do they want to be absolutely stone-free, one procedure? And then everything you have listed there is really an option. So shockwave lithotripsy is definitely an option for this stone. Retrograde ureteroscopy without a suction device is obviously a thing that we can certainly do. In my practice now, suction sheets are such a commonplace thing that I would probably use it for a stone of this size if I'm going to go ahead with retrograde ureteroscopy.
Thank you. Frédéric, what do you think about patient's perspective or patient choice in a case like this?
Very important. Not to give them too good expectations, especially if they are asymptomatic. But in France, for example, if patients have a tumor, they want it removed. They are not very keen to radiotherapy. So, for example, if they see a stone on their CT, they want it removed, and that's why we've seen a very impressive increase into the number of flexible ureteroscopy in the last years, and a huge decrease in terms of shock waves. Is because we can tell the patient that at the end we can endoscopically assess the absence of stone, especially with the great fans and in-scope suction devices we have now. But for these cases, like with a very small stone burden, I would go for shockwave without any hesitation.
Eugenio, what's your approach in San Rafael today?
I certainly start with a very extended discussion with the patient because it's correct. It's all a matter of expectations. And my gut feeling is that I can try to propose the patient shockwave, explaining very well and very clearly that it might not be the final solution for this case, but still it's worth trying. Of course, I will explain that it's lower pole, whatever, what are the chances for all of it. But the thing that Fred said before is correct. I mean, patients, they read a lot. There is, like in these times, a urge to have all problems resolved quickly, and not many patients would like this type of approach. But still, I would definitely try to propose shockwave in first place.
Thank you, Eugenio. So we propose shockwave, and the patient accepts shockwaves. 4 weeks later, the patient was stone-free. That's a low-dose CT scan. Frédéric mentioned about KUB and ultrasound. About this, the gold standard is a low-dose KUB. But these kind of results we can reach maybe in 70% of cases. There is 1/3 of cases where shockwave fails. So, Karen, if you have a failing shockwave and your approach is a retrograde approach, do you prefer an in-scope suction, or do you think in a FANS procedure with a ureteral axis sheet?
So either one, the scope that we have here in the United States is a little bit different. We use the CVAC scope with the aspiration, and so it is a bigger channel. The suction channel is actually separate than the irrigation channel, and the channel's 7.8 French, 7.9 French, so we can get out big fragments. I think with failed shockwave, either way, with the sheath or with the scope, I think the suction technology is going to be best, because you're going to go in there and there's going to be a million fragments. And so basketing is not going to be a great approach.
Okay, thank you. Frédéric, there is a question in the audience about the size of the fragments that you can remove using a ureteral axis sheet bendable. So what's the size of the fragments that we can remove safely?
I would say that 1 millimeter for 12 French, going to 1 millimeter fragments is reasonable. And over that size for 12 French, you're going to be facing difficulties, and the risk is the blockage. The risk is that the stone get blocked into the ureteral axis sheath, and you need to fragment it with a laser into the sheath, damaging the sheath, in raising the temperature, and also damaging the ureteral mucosa indirectly. So I would say that not over 1 millimeter, even if I'm a pure duster. So I would go very, very far into dusting, into very thin dust, as my mentor Olivier Traxler told me. Be patient always, and if it seems too big, it's too big.
Okay, Eugenio. So about the size of the suction channel, if you have a size of 3.6, how is the amount of dust that you can remove quickly and easily?
Actually, you find that the type of dust you are producing impacts a lot, because I mean, there are all these nice pictures of all type of lasers producing good dust, but the reality is that the small particles that can be aspired in a safe way, I would say, are those really smaller than a 1/4 of a millimeter. And in a way, as shown before by Fred in his very clear and wonderful images, was that you cannot remove more than 20 particles at a time by the same channel, which is not a lot. But at the same time, if you're able to produce good dust, this can be enough in order to improve the visibility during your procedure. And this is not something that you are going to throw away, because when the more dust you are producing and the better dust you are producing, the lower the visibility would be at the end of the day. So it's not a big impact in terms of number, but during your procedure, that can be really helpful, because better visibility means shorter operative time and better outcomes for your procedure as well.
Well, thank you very much. Very, very nice comments. So that's that question have been answered. So that's our second case. It's a real case. It was a car case that we treated a few weeks ago. It's a lady with fever and back pain, and you have this big stone in the left kidney, 1,600 millimeters square, and it's a hard stone, 1,480 Hansfield units. So she was with fever, with back pain. So what's your common approach in a patient like this, Karen?
Well, first, I mean, if she has fever, she's infected, so you decompress the system and place a stent.
Great. Frédéric, stents in the lower pole, in the upper pole, a perk approach in the lower pole. What's your choice?
So again, very, very long discussion potentially with the patients. How many surgeries do they want? Can they afford in some countries? Do they want an immediate stone-free? Do they tolerate some residual fragment at the end? So I would say that in these cases, if we are like reasonable, with considering the complexity of the stone, we could propose to the patient to go both ways, starting with a flexi, seeing how things are going, and if it's seems to be too big, maybe for a combined surgery. I mean, preparing the patient in supine position for this case in the first place, and saying to them that we may go from the side also, I think is a reasonable option.
Thank you. So we did the same that you say. So we put the patient in a supine position and we decide with the retrograde approach. And so you can see here the bendable erectile axis sheet. It is a big stone, you know, you can see in the X-rays. So Eugenio, if you are using this kind of suction axis sheet, do you use a different setting for your lasers?
Well, actually, this is the question. To date, we think we can use different settings in a way that perhaps temperature can be lowered in a more efficient way, and also that you are able to see better and to increase a little bit frequency in order to proceed faster, since it is a big stone. Honestly, we do not have clinical data to date, and not only clinical data, but also laboratory data to date that tell us that this can be done safely. But I mean, of course, if you have a good experience with these procedures and you know that all the system is staying really very well irrigated throughout the procedure, it could be that in a near future we could be more, I would say, or less strict with our laser parameters. But at the end of the day, I think we have to prioritize safety during our procedures. And I would not tell people to go quickly for very high power and high frequency. But still, in a way, the same way that you are able to increase visibility, sometimes you're able to increase a little bit frequency, which cannot be as higher as to become dangerous, but still higher as to be effective and safely proceeding. Yeah.
Yeah. Frédéric, if you were using TFL, what's your setting is usually how many joules in the beginning?
So for the thulium fiber, I always put high peak power or short pulse duration. So this is my first setting. Then I start with 0.5 joules, so low energy and low frequency, like 5 Hertz. And I make a test. So if the level of fragmentation or dusting is satisfying, is enough, I would then adapt the frequency to my ability to deliver the pulses only to the stone and not to the mucosa or the irrigation surrounding the stone. So I would say that if the anatomy is good, I would not be able to go over 20 Hertz because it has been demonstrated in the lab that over 15 Hertz, no pulses are delivered to the stone. So we are not able to control more than 15 pulses per second. It was, I think, was done by Sarah Best, if I remember well. It's very interesting because at the end, we are increasing the frequency, but we're not increasing our efficiency maybe. So I would stay low, and even if the conditions are good, like being able to see well, for me is similar to max 20 Hertz.
Okay, but Frédéric, what about the energy? Because here you can produce not only that, you can produce small fragments and you can suck it. So what about the energy using a suction axis sheet?
I would not change my way of setting the energy. I would start at 0.5. Maybe if it's not enough, considering the hardness of the stone in this case, I would go to 0.8 or 1 joule. But then I would consider not going over 20 watts, always 25 watts in the renal cavities. Recently in the French guidelines, we defined that the frequency and the power in the ureter was 15 hertz and 15 watts max. And in the renal cavities, 25 hertz and 25 watts combined. So we always try to keep that, and knowing that average power is energy cross frequency.
Thank you. Karen, there you can see that at the end of this first procedure, after 86 minutes of lacing time, the patient was stone-free. So what about overall procedure time in this suction era? Should we change our parameters? Should we stay thinking about 90 minutes? What are your thoughts, Karen?
That's a great question. I do think we can change it, probably. You know, when we use the scopes where we can measure intrarenal pressure, which was one of the main concerns with these suction sheaths, the pressure is incredibly low. And so we're concerned for sepsis. And again, we don't have the research to really prove this yet, but is probably lower. Same thing with temperature. We don't have it quite yet, but my guess is the temperature would be lower when you're actively suctioning out all of the fluid. So I think, you know, it's always a pros and cons of going a little bit longer, but I have felt more comfortable going longer in the era of suction.
Okay, thank you. Eugenio, can we combine in-scope suction with the access sheet? There is any data about that?
Actually, this is a really nice concept, because at the end of the day, it's like putting together the two new kids on the block. From the theoretic point of view, it was shown very well before by Fred that you could theoretically increase the number of expired particles when you're doing this. Actually, to me, it is more important when you're using fans, the ratio between the size of your scope and the inner diameter of the sheath, because that is really determining the number of particles you're expiring. So in order to achieve, I mean, it doesn't make a lot of sense to have a big scope with suction within an access sheath with suction, but it would be more important to have a smaller scope within an adequate access sheath. But still, it's still feasible. I can tell you from the practical point of view that starting to use aspirating sheath was a little bit of a nightmare in my OR, because aspiration is not very well dealt, and it's not precisely dealt by nurses. So it's always deciding the type of aspiration pressure you want to set. And I can tell you it's not always the same, the effect that you get from the renal cavities according to the different cavities profile. So it is very, I would say, fascinating, but adding too much aspiration then starts a cycle, adding more irrigation because you want to distend cavities. So intriguingly, it is interesting to have both these associated suction methods, but at the end of the day, too much suction is not good because you will collapse cavities, and I don't know if it is really beneficial.
Thank you, Eugenio. It's a different procedure. It's not the same that we were used to do. So there is a nice paper for our friends Vinny Gauhar saying that we need almost 3 French of difference between the scope and the ureteral access sheet. But it's very important the setting, it's very important the movement. But what about the irrigation, Frédéric? How do you manage the irrigation when you are doing suction procedures?
This is the question. We don't really know yet. We don't really know because we've been told for a very long time to stay low in terms of irrigation to avoid pielovenous backflow, fornix rupture, sepsis, and many stuff like this. And by now, and since now, we have the possibility to increase irrigation now because we are increasing the outflow. So we can increase the inflow, but we need to define how high. And this is very difficult. And I think for that, to have pressure and temperature monitoring will allow us to define it. And I would not I would not recommend to go high at the moment for any endourologist before we've been defining and trying to define it in the lab in the perfect conditions. And then we need to adapt it to the in vivo conditions, because at the moment, nobody knows what elasticity do you have in your cavities or in mine, and how are they different? We don't have these results. I mean, patients in Buenos Aires are not the same than in France, are not the same than in India, are not the same than in the US. I've been recently to the US and I've seen the patients over there, and I can now tell you why they are not doing a lot of flexible uteroscopy for more than 2 centimeter stones, because the anatomy is a bit different, patients are different. So, I mean, the response to irrigation may also be different.
No, thank you. There are many things that we don't know yet. Karen, do you use a pump when you are using CBAC or Calypso?
I use an automated pressure machine. You know, you just go through so much fluid too, from a nursing perspective. It's just better to have the bigger bags and it's automated. I don't use that without the suction technology. I'll just use a pressure bag, but I use the automated pump with the suction technology.
Thank you, Karen. So we are doing this kind of procedure in the last 4 or 5 months. And one of our first thought is it's very important, the assistance way that they give you the fluids, because without irrigation, there is no suction. I think that that's very important topic. There is no way to have a clean feel and to suck the fragments without the right suction. Due to that, we are not using pump because it's very variable. It's a dynamic procedure. So we need, today, we need the human, you know, knowing what's going on at the right moment. So thank you very much. And the last case is a case, seems to be a simple case. We have this man with a 5 millimeters distal stone, but he has a homolateral, a contralateral, small renal stones. So Karen, what's your approach in a case like this in Mayo Clinic?
So, you know, if he failed a trial of passage for the distal stone, I would offer ureteroscopy. I personally always have a discussion with the patient and see if they want me to treat the contralateral side. If I'm treating a distal stone, I will always 100% go up to the kidney and treat that side, so the ipsilateral side will get treated. But if the patient has stones on the other side and they would like them treated, I always offer that as well, assuming that it's not a huge stone burden, would not add on too much time to the anesthesia.
We offer him some weeks of waiting, but the stone was still there. So we remove, as Karen mentioned, with the simmeridoscope. And that was very easy, but you can remember you have these small calcium images on the CT scan. So the question is, Frédéric, there are stones or randal plaques? Can we differentiate using the CT scan?
Difficult question. I would say that only based on the CT, if you have only one image of calcification that is very, very round, like in a circle, and that the density is a bit higher than 600, I would not go for a randal plaque, honestly. I would go for a stone. In this case, for example, I would go for stones. But if you have the same images in all the calyxes, for example, I would say this is an argument for randal plaques. But it's very difficult to make the difference. You can do a CT urogram if you want to make the difference. It can help you to see if this is in the bottom of the calyxes or at the fornix.
And that's very difficult. So you can see here at the right side, as Frédéric mentioned, it was a randal plaque, but in the other side, there was a stone in the left side. So it's very hard to differentiate what it is on the CT, just based on the CT scan. Eugenio, can we perform bilateral procedure at the same time? It's safe?
Actually, it is a discussion that you have to have with your patient, and that has to happen according to your skills. As suggested before, if the stone burden, like in this case, is not very high, it is doable. Just remember that there is a New England Journal of Medicine paper from 1.5 years ago that tells you that whenever you are treating stones, if you are treating non-symptomatic axillary stone, you are reducing the likelihood of relapse and of request of new medical assistant procedures, which is important in terms of health resources allocation, of course. I don't think in this case the man is young, the stone burden is low, so it is worth trying to have a check like you did in this case, definitely.
And do you think that suction plays any role in a case like this? For example, in scope suction?
It might be. It might be in a way. You know, when you have these very tiny stones, the patient is not pre-stented and it's a calcium oxalate monohydrate. So you try to use some laser sometimes. You create a fragment and then the fragment, it's like escapes in front of you and you are not able to catch it. And it's very small. Perhaps suction can be a good way to recover the small dust particles. Yeah, that can be an option. Of course, always discuss with the patient that when you are seeking very small stones and looking for very small stones, it may happen that you are not able to find it during the procedure, and then you repeat the CT scan and the patient comes at you complaining that the stone is still there, so it can be a tricky situation, of course.
Thank you, Eugenio. So we have a few more minutes, and that's our last case. You can see a big volume stone that is blocking the upper pole of the right kidney. Karen, do you think there is a place for retrograde approach in a case like this?
I think if the patient's high risk for a percutaneous procedure, then there's a place, you know, with a stone this large, it's going to be faster just to do a PCNL or an ECIRS, and then you can combine the two. But I think going purely retrograde is going to take longer, probably more than one procedure. So if they can go percutaneously, I would recommend that.
Thank you, Karen. So we saw patients for shockwave, patients for insuction, patients for fans procedures. But in a case like this with big volume, the combined approach, I think that is the right decision. So Eugenio, if we are doing a combined approach, can we use suction at both sides? There is sense about that?
To me, there is sense of using suction through the PCNL tract, of course. During combined surgery, I always find the role of the scope more ancillary rather than operational. So I never ask my residents who are doing retrograde to laser during the combined surgery, but they assist me. For instance, in this case, it could be interesting to do some, you know, where all the stones, they are protruding into the calyces. It can be difficult to pass the guide wire, so you would need some retrograde lasering to advance the guide wire from the percutaneous tract. And in that way, the stone is big, so some suction from below may help the initial lasering just to make the guide wire passage. So in that way, it can be helpful, yes. But routinely, I would say that the most important suction you have during combined surgery is the one from the percutaneous tract.
Oh, thank you, Eugenio. What's about the time limit of the procedure, Frédéric, in combined approach? Is the same? Can we add some more minutes?
I would say that it depends on the size of your tract. If you're doing like a regular PCNL with a flexi during combine, you're having a very low pressure because like a 24 to 30 French tract provides you a very low pressure in the renal cavities. But if you're using a very like a mini PCNL with a lower ratio between the implants and the scope, you're back to the retrograde conditions with high pressure. So I would limit myself to 90 minutes. I mean, in France, especially because of the risk of sepsis, we've said that 90 minutes of intrarenal procedure, but the limits. But if you see that in 5 minutes you can end the procedure and avoid an ancillary one, let's go for 5 more minutes. But if you know, and I would thank Darren Smith for that because he taught me that in London recently, that if you see that you will need 20 minutes more, let's stop here and avoid.
Oh, thank you so much, Frédéric. And thank you, all of you. You have been very kind. Your lectures were amazing. And I would like to hear your last thoughts in a few minutes, in a few words. Karen, please. What are your thoughts about suction in your clinical practice today?
Yeah, it's a huge part of my clinical practice. I think this is probably the most exciting thing to happen to endourology in a very long time. I think from a research standpoint, it opens up a ton of work for us. We really just don't know that much about it. We know it's great, but we don't know the best way to use it. And so I think in the next year or two, we're going to have a lot of success. I mean, if you think about it, everything that we have out there is pretty good, but it's only the first generation. And so we're going to get better and better devices, and I'm excited to see where that goes.
Thank you. Eugenio?
I think we are at the beginning of a revolution, especially in retrograde surgery. And it's very exciting time ahead of us in terms of novelties and, again, things we can do to improve our outcomes.
Thank you, Eugenio. Frédéric?
Yeah, I mean, I agree with Karen and Eugenio, of course. And I would say that laser has been the hot topic for the last 25 years. Now, maybe for 20 years, it's going to be suction. And in the next 20 years, we may going to be like doing a lot of robotics, ureteroscopy. But from now, I'm sure that suction is going to be a hot topic. And at every conference and every year, we're going to speak a lot about suction, in-scope, fans, and maybe other options that we still don't know yet, are not aware yet.
What's great to hear you. I am glad to can hear your thoughts, your knowledge. You have been very kind. Thank you, Cassia, and thank you, Wendy, for inviting us. And Cassia, please, if you can close the webinar.
Yeah, thank you all for sharing your knowledge, sharing your experience. I think the discussion, especially discussing the cases, was very interesting and very rewarding for everyone. So thank you, and hopefully see you next time.
Thank you. Have a good afternoon. Thank you, guys.
Good afternoon.
Thank you all.
Bye.
Thank you so much.
Thank you.